hello.
હવે you are live આવે છે.
Hello students, hello. Just tell me if I am visible to all, audible to all.
Sorry, creators or creators?
I think it's showing now.
Yeah, you
Yes,
are
fine.
live.
Hello. Good afternoon, students. Good afternoon. Welcome all of you to the yes. Okay, thank you very much. And yes, Varsha Thakur. Yes, good afternoon, Tony DBM. Thank you, Tony DB. Yes, very good. So, is the chat box also all working? And can just somebody type in the chat box so that the chat box functionality is there? And yes, we are live. Yes, from where we are streaming, there might be slight lag. So overall, the exam, yes, Hankit, good afternoon. Yes, okay, great. Okay, so let us begin our session. And this is, as all of you know, the yesterday exam, July 25 OBGY early recall. As all of you know, this is all. Thank you all the dear students for sending in so many thank you messages and so much love and appreciation, and also the questions. And as all of you know, these are early recalls. Some options may be different, some may be slightly this. And before we proceed quickly into the recall, I request all of you to download the OGGuru app on Android and iOS. For iOS, use this ORG code YYMSTV. And for all your future examination, this is the WhatsApp number. Please, those who are planning to give exam in December, get in touch with me right away on phone and WhatsApp on this number. This is thank you for all your love which all your students, sir. Thank you very much. Your lecture OBGY was the best, and because of this, so many questions directly from your lectures. And yes, the paper was slightly tricky, no doubt, but those who had done the master class can get it very well. Okay, and more about this later on, about this 6 months masterclass. All those who are preparing for the December examination, just exactly in 1759 you will get all the theory lectures, MCQ, rapid revision, and beautiful handwritten notes. So let us discuss that later on. And now, yes, and I want all of you to be participative. It's going to be an informative session where we'll discuss not only this recall and also some more important information, so that if you are also preparing for upcoming examination, this video will be beneficial to all of you. Yes, okay. So fixative for pap smear. Yes, anybody? Very easy, very straightforward. आपके पैथो के टीचर ने भी सिखाया होगा. And of course, we had also discussed it. Yes, anybody? Yes, kind human. Hello. Yes. So let it flood the chat box, please, so that I know all of you. And please give the answer. Right, wrong does not matter. Yes, this is your 95% ethyl alcohol or ethanol. I'm sure all of you must have got it correct. Okay. Now, before we just go ahead, my assessment overall, yes, 30 questions. Okay, almost as predicted, OBGY is the single most important subject, and 30 questions came in OBGY as predicted. And majority, yes, very good, Swati, and majority of my students have done extremely well. Yes, my assessment paper was slightly difficult overall, and OBGY was also one or two questions were very tricky, but if you see, it is very easily possible to score maximum in OBGY 28, so you can easily score. And yes, very good. Yes, perfectly correct. Very good, all of you. So let us move on to the next. Variable deceleration is seen in. Yes. So what we have got, early deceleration किसके साथ होता है? Early, there are three types of deceleration. Early deceleration is in head compression. Image also we have shown you. The late deceleration is very dangerous. That happens in uteroplacental insufficiency or fetal distress. And what is the answer? Variable deceleration, cord compression. I'm sure all of you must have got it correct. Okay, specifically, when do we get this? One more MCQ or one more variation. If you have oligohydramnios in labor, okay, when I have a patient who is having oligohydramnios, then during the labor and uterine contraction, the cord can get compressed. So there is a variable deceleration. Yes or no? Thumbs up if all of you got it correct. Isn't it? Yes or no? Yes. Very good, Varsha. Thank you. Yes. Okay. Similarly, moving on to the next MCQ, OC pills not protective for. I'm sure all of सबने तोड़ा होगा. Straightforward question. Yeah, but I will discuss that, Randhir. Yeah, okay. Spotting, missed periods, cervix, investigation showed. Yes, yes, yes. Very good. I'm coming to that. Beta. Very good, Randhir Babu. Yes, very good. Thank you for that. And we are discussing that. Yes, and we are discussed that also. CADA's role also. Yes, very good. So keep posting in the chat box whatever you feel. Yes, yes, yes. Okay. Yes. So OC pills not protective for all of us. No CEO. Colon, endometrium, ovarian is what it is protective for. Cervical cancer, slightly increased risk. Even breast cancer after prolonged use. Breast cancer also the risk is increased, and mainly hepatic adenoma. Yes, hepatic adenoma also increase. So cervix, breast, and hepatic adenoma are going to be increased, and protective for CEO. All of you know that. Is this crystal clear to all of you OG in the chat box? Yes, this is what Randhir Babu was telling me. Thank you for that. Lady of question, suspected ectopic spotting. Very good. Okay, history of spotting which can happen in ectopic. Spotting, missed periods. Okay, thank you. And what it is? Yeah, we are coming to that classification. Yes, Sandeep, we are coming to that OSIP. Okay, yes. And beta HCG to repeat after 48 hours. Can anybody tell me why? Why after 48 hours when I repeat, what will happen? And a virgin MCQ, what is this called as, everybody? Yes, this is the Cadder's rule. Very difficult virgin MCQ. It will come in the future, this law. Okay, what is the Cadder's rule, and can anybody tell me how it will differentiate? How it will differentiate? So what is this beta HCG after 48 hours? When do we do? Because when it is a doubt that whether it is a intrauterine pregnancy or a ectopic pregnancy, what happens? Yes, 48 hours is the answer, because in normal healthy intrauterine pregnancy, the beta HCG will double. Is this understood to all of you? The beta HCG will double, and that is the logic, which is a practical thing which all of us uses. Yes, so if the values are going to double, okay, 2 days or 48 hours may the HCG here will double, then we are dealing with a intrauterine pregnancy. And what happens in ectopic pregnancy? Yes, ectopic pregnancy, the HCG will increase, but it will not double. Just remember, it is going to be less than 66% increase. This PG level may come in the future examination. Keep in mind that example I'm just giving you. Example, if the initial level is 1000, here the levels will become 2000. And what will happen in ectopic? So levels will become 1200, 1300, 1400, like this example. Is this understood to all of you? Thumbs up and OG in the chat box. So just remember, beta HCG such doubt hai to repeat after 48 hours. That is the Cadder's rule. Yes, it is W. Yeah, okay, okay. Yes, eligibility criterion option. Yes, okay. Okay, yes. Moving on to that, I think very simple. I said short topic. Primary amenorrhea is a must-know topic, and all of you must have got it correct. So many times on my YouTube session in the app discussed primary amenorrhea, absent uterus. What are the only two possibility? Sir, whenever we have this combination of primary amenorrhea, absent uterus, only two options are to be kept in mind: Mullerian agenesis and androgen insensitivity syndrome. Yes or no? And here clear cut de diya, raised as female. Why? Because I told you, androgen insensitive, they are like models, supermodels. Remember, we had said this in my lecture. Height, weight, breast development, everything like a perfectly normal female. But when we do the karyotype XY, अरे ये तो लड़का है. Okay, yes, perfectly correct, Shai Chauhan. And in RMKH, Rokitansky, Mayer, Kushner, Hauser, it is 46XX. Very good. The answer is this. Yes, this is the answer. Just extra information I'm giving you so that quickly revise ho jayega. And one more difference, what it is? Yes, breast is well developed in both of them. That is not a difference. Breast is well developed in both of them. And what else? Look at the axillary and pubic hair. Yes, axillary and pubic hair is what we check. If the axillary and pubic hair is very well developed, that goes in favor of RMKH, and here axillary and pubic hair will be absent. That is one more thing, because it is androgen insensitivity. Okay, super. I'm sure all of you must have got this correct. Clinical case scenario tha. Yes, I'm so happy. I said this is a virgin MCQ. And finally, as we say, virginity broken or virginity lost in this FMGE July 2025. I got two questions. Uh, uh, two questions were there. Either it was a best screening test पूछा था कि core test पूछा था. What is core test directly पूछा था. Anybody can tell me. Anybody can tell me what was there. Okay, and all of you, yes, anybody, what are the options? Okay, so was it a pap smear and VIA or pap and this? Yes sir. And pap means specifically when we do HPV virus, we have to do liquid based cytology compulsory. I told you that sir, when I want to do, yeah, core test was asked, perfect. So this is the perfect reason. Core test is what? Thank you, Shahid Randir Babu. Yes. So remember this, that liquid-based cytology, the advantage is it is a much better picture, clear picture. I told you PAP gives us a crowded and dirty picture. So liquid-based cytology and HPV, that is the core test. And then yes, and then remember we can do every 5 years. Okay, remember this. Pap smear is every 3 year screening. If we are doing only pap smear, we do every 3 years. The advantage is if we are doing a co-test, the screening can happen every 5 years only if it is normal. Yes. So VIA was other option. Yes, but if PAP and VIA is not the answer, visual inspection, it is PAP and LBC and HPV. Co-testing may we check for the human papilloma virus. Very good. Superb. Excellent. Thoko tali. Yes, yes, yes. Now again a straightforward, I'm sure multiple options were given to you, and absolute contraindication for IUCD. Anybody? Yes. Undiagnosed vaginal bleeding. Very simple, undiagnosed vaginal bleeding, because we are not sure what it is. Other absolute contraindications is our pregnancy. And also remember, my dear student, it will come in the next exam also, acute pelvic inflammatory disease also is our absolute contraindication. Is this understood to all of you? And there, of course, the whole list is given in the last day reading session also. We have read all the notes, and beautiful handwritten notes may also this are there. And there's of course a whole list of further distorted cavity and following vesicular mole evacuation also. Yes, I think sure all of you must have. Yeah, we are coming to that. 44-year-old history. We are coming to that, Randir. Yes, thank you. Keep on posting. Yes, yes. Moving on to this. Yes. Now, please understand this. Recurrent endometriosis. Okay, there is a lady who has undergone a treatment for endometriosis. Recurrent endometriosis. Some age was also given. Para 2 living 2. That means family is complete and even tubal ligation is done. Okay, tubal ligation is done, or laparoscopic tubal ligation was done. I think laparoscopy tubal ligation was done. Okay, and what do you do next? Anybody, what do we do next? Chalo, the 3-4 options were there. Yes, please understand this, that medical management is only temporary. It is only temporary, because once we give the medicine, the action is there, the symptoms become better. Age was 38. Very good. Okay, 38 years old. Thank you. 38 years old. Fine. GnRH analogs is a temporary treatment. Once the medicine action is over, it comes back. And remember, this was a trick thing, student. Only hysterectomy is wrong. Only hysterectomy is wrong. Why? Because sir, when I remove the uterus, still anybody, what is the most common site of endometriosis? Yes sir, ovary, chocolate cyst. So I will, and it is a estrogen, yes or no? Yes. Very good, Swati. So hysterectomy karenge, bilateral oophorectomy will be required specifically for endometriosis. Okay, and also what we do, all the all, there might be other endometriotic lesions also in the pelvis. What are those lesions, my dear student? So there could be blue lesion, red lesion, matchstick burn spots, black, all that lesions also we go and we burn them. Electrocoagulation, is it clear? Yes. So bilateral reflectomy plus we can do the electrofulguration or electrofulguration of the endometriotic lesions which are there in the pelvis. Okay. Yes. Yes. Okay. Thank you. Yes, we are coming to that MCQ. We are coming to that. Very good. Very okay. So recurrent endometriosis basically family complete दिया है in a patient where I want to preserve the fertility. We just do the chocolate cyst excision and adhesiolysis. When family complete hysterectomy we will go, and of course bilateral oophorectomy will be done also. So that is the answer. Yes. Now this is the medical eligibility criteria. I am so happy. Really. Okay, I have told you in my lectures category 4. Okay, ulta पूछ लिया. Category 4 is absolute contraindication. Category 4 means the word as absolute contraindication, and category 1 means where we can use it. Where we can use it, there is no restriction, we can give it. And anybody, okay, yes, HIV patients, only thing one careful, hypertension will depend. If it is hypertension severe, if it is severe hypertension, it becomes category 4. Okay, severe uncontrolled hypertension becomes category 4. Hyperlipidemia also category comes in 3. And diabetes is category 3, but diabetes with vasculopathy. Okay, my dear student, याद रखना, next time आ सकता है. If it is diabetic with vasculopathy, okay, diabetic vasculopathy, it is again category 4. Is it clear to all of you? So HIV may there is no problem. Of course, you need to tell the patient also to use barriers, but HIV OC pills can be used. Only thing, if they are using on enzyme inducers, what is the trick? If they are on enzyme inducers, slightly failure rate is on the higher side, as you know. Yeah, that is fine. Indian classification, that's also okay, no problem. MEC is WHO, and if they say Indian also, no problem. Basically category 1. MEC का मतलब है medical eligibility criteria. Okay, medical eligibility criteria. So that is fine. If it's WHO or Indian, almost it is same only. Basically HIV patients we can use. Only thing, just we have to be caution. I'm just saying, writing it as a caution, that if they are using enzyme inducers, your pharmac teacher will teach you which are enzyme inducers, then slightly the failure rate is more. Okay, if they are using certain drugs, we all know, then slightly increase, but they can use, there is no restriction as such. That's just the extra information. Yes, now this is very important MCQ. Here they had also given some cervical dilatation at some 2 centimeter was there, and now there is basically this, it was showing slow progress. Anybody slow progress? So kya answer hoga? So this is of course a normal partogram, but in the question from what I have got, yeah, WHO MEC1, very good, thank you Sam. Okay, from what I had got was that the partogram has crossed the alert line. Partogram has, this is normal. Okay, if it is on the left of the alert line, that is normal, but it has crossed the alert line but not yet touched the action line. Yes or no? That was the question which all of you have told me, and yes, very good. You do not do LSCS directly. Basically, when it crosses the alert line, the dictum is yes, you need to be alert, reassess the situation, and we can go for artificial rupture of membrane, which will augment the labor, and also giving oxytocin can be done so that we can augment the labor. Okay, woman 40 weeks was given, that is fine. Okay, very good. Chalo, 40 weeks lady, very good. 40 weeks pregnancy, that does not matter. And can anybody tell me, suppose if the question is if it touches the action line, to kya karna hai? Next year question can come, sir, it touches the action line, then what is the answer? Yes, yes, alert line cross, very good, Maulini Raj Dodia. Yes, if it touches the action line, then immediate, you cannot allow labor to progress further. Yes, action line cross ho gaya, then yeah, action line touch ho gaya, then there was LSCS has to be done. Is it clear? Is it clear? 4 centimeter dilated. and after 4 hours 6 centimeter. Yes, correct. Even after 4 hours it is still, yeah. So rather than just observation, no, you can just observe kind human, or the observation is if it's on this side, if it's on the left of the, if it's crossed alert line, definitely you have to be alert. You just can't do observation, you have to go for ARN. That is what I feel is the better answer. And that yeah, experiment also, but there, but still, as it has crossed the alert line, if it's progressing on the left of the partogram, then we can go with or expected management or just observation. Yes, is it clear? Yes, here definitely ARM, medical management. Yes, oxytocin we can add it. Okay, yes, for 4 hours, after 4 hours also she has just touched 6 centimeters, it crossed the alert line. Yes, moving on. Yes, now this question, remember this, I'm so happy again. Patient of PPH, majority students have told me, sir, it was a vaginal delivery. Don't confuse this with placenta invading. Wo separate question we are discussing in some time. This is your postpartum hemorrhage happening. Oxytocin has already been given, and before proceeding for our other surgical management, what do we do? Yes, balloon tamponade. Okay, I've also told you what is it. It's called Bactri balloon. All of you, OG in the chat box, we had discussed this in our even shortcut live. Bactri balloon tamponade. Or in India, what do we use? Anybody? Something very simple, an Indian contribution. Yes, condom tamponade can also be used. Very good. Okay, condom tamponade can also be used. And remember why specifically, how does it work also, I will show you, my dear student. If this is the uterus and it is not delivering, then whichever catheter you take, balloon or condom, and thank you, Sharif. Okay, and it will give a tamponade effect, and it is definitely to be tried first before you open up the patient. Suppose it is LSCS already, then you can try with the uterine artery ligation, because the table it's on the OT table, we have already opened up the patient. Following vaginal delivery, before we proceed for surgical, definitely balloon tamponade or condom tamponade or Bactri balloon tamponade. Yes. Surgical method, agar beta, if the question was asked, then initially it depends. If it's the bleeding, then we can try the uterine artery ligation, and then we go to the stepwise ligation, and finally even compression sutures, and last is the hysterectomy. That is how we proceed in the surgical management. Yes, all of you. Yes, very simple. Anybody? ये भी question था for the face. I showed you face is from year to year. In face, we can get mento anterior, or we can get mento posterior, and mento vertical is for what? Mento vertical 14 centimeter is for brow. Even in the yes, same PYQ last year also. Correct. What tamponade, balloon tamponade question was the last year also. Very good. And last FMGE also. And brow also in my first strike exam, if you had given in that first strike, we discussed this. And the answer over here, submento. Okay, submento bregmatic. Other option they will give you. Yes, submento bregmatic is the answer for face presentation. Mento antical, or yes, for mento vertical is for brow. Perfectly correct. Excellent, all of you. Thoko tali. Okay, now, yes, this is what I am so happy. Here, what was the age of the patient given to you? Or was it like perimenopausal age group? I think there was the question. She is having heavy menstrual bleeding. Yes, executive. Thank you, Sharif. Yes, MVP question, of course, yes. This was some executive, high-profile lady. I think it was given like that. Executive, working, yes, it is disturbing her life. Okay, some disturbing her daily routine. Okay, and what do you do? So this, I am so happy. I have told you this, okay, whenever there is a perimenopausal lady, see, endometrial hyperplasia is actually a histopath diagnosis. It's a diagnosis based on histopath. So they should give you, okay, on ultrasonography, there is a thicken. Yes, very good. But please understand, rather than a pipelle biopsy, rather than just doing a pipelle biopsy or a DNC, the question was about the best. Yes, best, and therefore hysteroscopy and biopsy. Read my notes. This is the best answer. Is this understood why? What is the dictum, my dear student? याद ये रखना है कि age was 48. Okay. Old lady, perfect. Okay. Yeah, okay, age is 48 years old, perfect. Yes, so here, my dear student, the question was that what is the best, and therefore for best we prefer hysteroscopy and biopsy. Why? Because remember, student, yes, the dictum is that any perimenopausal, again this was the question in the first strike exam what I had given you, in perimenopausal HPE, histopathological examination is mandatory. Why mandatory? Anybody? What is to be done? Yes, rule out. Yes, we should do full workup and rule out. Why? To rule out endometrial hyperplasia and endometrial cancer. Is this understood to all of you? And in such cases, my dear student, hysteroscopy is the best. Why? Because in hysteroscopy, we might see a small polyp also and we can cut it. And hysteroscopy may we can see particularly which area is looking abnormal. We can take the biopsy from that area, or we can get a polyp which could be causing endometrial heavy menstrual bleeding, and therefore hysteroscopy is the best, or the best, I think. Two options. Yes. Yeah, high socioeconomic class, very good. So hysteroscopy plus biopsy is definitely the better answer compared to office biopsy or DNC. Is this understood to all of you? Because best pucha hai, and I repeat that. Okay. Yes, coming to that. Yes, yes, yes. Okay. Yes. Now this is again, I'm sure all of you, your radiology teacher must have also taught you, and this also is a very standard thing. Early pregnancy spotting and missed abortion. What is, when do you make the diagnosis? Yes, so anybody? Yes, 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 I think mean gestational sac diameter was also given. Okay, G sac diameter was also in one of the option. Anybody? What is the answer? Yes. Okay, sir, what is missed abortion? Sir, either when the fetal cardiac activity starts and then it disappears. Okay, either the fetal cardiac activity starts and then it stops, we call it missed abortion, or specifically when the crown rump length has already crossed more than or equal to 7 millimeter, and still we are not able to, we are not, her mother was correct in this kind of age is normal, and no, yeah, correct. I read that option also. The other mother said that you can neglect the situation. Never neglect. Mother can say anything, father can say anything, husband, neighbor can say anything. We have to give the correct advice. At perimenopausal patient, you need to rule out endometrial hyperplasia, endometrial cancer. That is the dictum. Please keep in mind. Surely this question will be repeated. Yes. So this is what, yes, I'm sure all of you must have got it correct. Okay, it is no cardiac activity in spite of CRL being more than 7 millimeter. Perfect. GSAC diameters are also given, but that is this. Okay, if it's more than 25 millimeter and still, or if it's a only empty GSAC, okay, empty GSAC and no pole. Okay, no pole also seen. If it's only a GSAC and no pole, what is that called? Blighted ovum. Yes, blighted ovum. Moving on. Yes, again this was a repeat, and so happy we discussed this. Fetal anemia. Fetal anemia is mainly which topic? Yes, RH isoimmunization or any other result. Basically fetal hemolysis is happening. And what do we do? Middle cerebral artery Doppler. Yes or no? This was again a repeat. Middle cerebral artery Doppler, and specifically what do we study? The peak systolic velocity. Peak systolic velocity. Uterine artery is for mainly prediction. Uterine artery Doppler is for prediction of preeclampsia and IUGR. And actually, when there is a patient of IUGR, then at that time the umbilical artery Doppler is the most important. Very good, Swati. Excellent. Okay. IUGR may we look at the S by D ratio, absent flow, all that. Very good. If it is more than 1.5 multiples of median. Very good. Excellent, all of you. MCA Doppler, I'm sure सबने तोड़ दिया होगा. Okay. Placement of the vacuum cup. So happy. So happy. Again, no longer a virgin MCQ. I'm sure all of you. In fact, remember, I draw the picture also in the class and I tell, I tell you, okay, chalo, tell me option 1. If this is the posterior fontanelle, if this is the anterior fontanelle, where will you place the cup? Is it anterior to anterior fontanelle? No. Is it posterior to anterior fontanelle? No. What is it? Yes, sir. As close to the posterior fontanelle as possible. Specifically, what is it called, everybody? Flexion point or the pivot point, discussed in all the MVPs, masterclass, and of course in the rapid revision also. Yes, just at the posterior fontanelle or as close, and it is called. And specifically if they want to make the question tougher, yes, please understand this, at the center of the cup, 3 centimeter anterior to the posterior fontanelle, there should be the center of the cup. Basically, remember this, okay? Yes, center of the cup should be on the flexion point or the pivot point. So automatically the cup will come as close to the posterior point. So important. Yes, instrumental delivery, every year the question comes. Yes. Now this, my dear student, I felt this was unfair and this was the toughest MCQ of this paper according to me. There is no doubt. Image based question given and McDonald modified, McDonald Shirodkar, all that. Now all of you know, please understand this, कि the question kya hai? Yes, okay, when McDonald is very simple. McDonald, all of you know, it is a purse string suture, goes from here. So McDonald is a purse string suture. It is a very straightforward thing. Whenever we are, why? Because understand this, McDonald is somewhere between. McDonald stage, just for your knowledge, McDonald stage we place between the internal os and external os. Somewhere in between here we put the encerclage. I want to go as high as possible. So Shirodkar is tougher, but Shirodkar is better because here we are putting at the level of internal os, which is the main problem, because if the internal os is open, there is a problem. Yes, very good, San. Very good, San. Okay, yeah. Okay, yes. Okay, yes, more than okay. Okay, so here clearly we are seeing that we are opening this flap. So whenever we are opening this mucosal flap and taking it posterior and then passing a knot. Okay, so now in actually Shirodkar, the knot is placed posteriorly. The knot is placed posteriorly and modified Shirodkar becomes the answer, perfect answer, because here from the image we can see that pura circumference aage aake the knot is going to be placed anteriorly, the final knot. So yes, the toughest question of our, we can officially declare this as a tough question of, or the toughest question of this year FMGE examination, but I'm sure many of you would have got it correct because it was not McDonald and it is not this. So yes, modified Shirodkar is the perfect answer. If this was not in the option, then you can mark Shirodkar, but definitely this is a cervical. It's a encerclage operation, also called as os tightening surgery. Moving on, simple. Correct. That is fine. Okay. Image based question. Clear. Repeat. What is the sign? Bimanual examination. Approximation of the fingers. I'm sure all of you must have been, eyes must have lit up when you see this picture. And Hegar's sign. Hegar's sign. We have told you always 4-5 signs in pregnancy. Goodell, Jack humor, all that questions are coming every year and do it very well. So this is the Hegar sign. Nothing much to discuss in this. And what is this again? Yes, there was a clinical history, clinical scenario that the head has delivered and the shoulder is stuck or shoulder failed to deliver. This is shoulder dystocia. Yes or no, my dear student? Yes. And what it is, clearly we are hyperflexing the maternal legs, hip hyperflexion and abduction, so that the shoulder can get dislodged. All of you must have got it correct, the Mac-Roberts maneuver. Okay, Mac-Roberts, so please keep this picture also in mind. And hip hyperflexion, onto the maternal abdomen, Mac-Roberts maneuver. Okay, moving on. Yes, I'm sure सबको पता होगा. This is a no-brainer image-based question. What is this prominence? We are seeing hair, tooth, sebaceous material, all that, and this is a dermoid cyst or a mature cystic teratoma. Remember, rocky Tansky protuberance also, and also ओके यस यस. कौन सा वाला नहीं था बेटा? या डर्मोट, ये वाला नहीं था. ओके, ये नहीं था. ओके ओके यस, मेच्योर टेराटोमा और डर्मोट सिस्ट, डॉक्यूटेंस के बारे में. एंड आल्सो रिमेंबर इट्स वन ऑफ द मोस्ट कॉमन डर्मोट सिस्ट के बारे में. आल्सो वन मोर इंपॉर्टेंट एमसीक्यू, मोस्ट कॉमन ओवेरियन ट्यूमर टू अंडरगो torsion. It is the most common ovarian thing, or maximum most common for torsion, dermoid cyst. Okay, yes. Okay, moving on to this. Yes, again there was a history given to you, and this is very simple, that a lady is having a delivery. She has delivered at home or delivery on the way. Pregnant lady delivery on the way to the hospital. That is what some students told me. And this is our uterine inversion. Don't consider it with prolapse. Okay, prolapse may remember always cervix will. This is clearly inside out. What happens is in prolapse, in your inversion, the whole thing comes inside out. Inside out is the uterine inversion. हाँ बेटा वो डिफरेंट था. प्रोटेक्ट किसको करते हैं वो डिफरेंट था. यस नो बेटा स्वाति, दिस इज नॉट प्रोलैप्स. यस, दिस इज नॉट प्रोलैप्स. प्रोलैप्स इज डिफरेंट. इन प्रोलैप्स स्वाति, प्रोलैप्स, दैट्स अ ट्रिक. प्रोलैप्स में always the cervix will be the leading point. I've shown you, told you so many times. In prolapse always the os will be seen. Okay, yes. Okay, so prolapse mein, whether it's first degree, second degree, third degree, fourth degree, always the cervix will always be seen. So prolapse will be always if the cervix is seen. Here we are not seeing cervix or the os. If it is seen, then it is only possible for prolapse. Okay, is it clear? हाँ, okay. हाँ बट दैट्स ओके. मल्टीग्राविडा या दैट्स ओके. मल्टीग्राविडा था, दैट्स ऑल्सो ओके. हाँ ओके, मल्टीग्राविडा पेशेंट, दैट इज फाइन, whatever. Okay, multigravida, but from the picture it is uterine inversion. So try to repose it, immediately shift to the OT, all that. Yes, now this again was just a mathematics. We generally bishop scoring we've discussed in our post-datism chapter, and student can tell me exactly what was asked, but we should all know okay sir, in bishop scoring, dilatation, effacement, station, cervical consistency and cervical position is what is taken into consideration. In modified bishop we are going to replace the, because effacement is very subjective, we replace it by cervical length. Okay, cervical length. So from here what I have got it from the student was that station was somewhere -2. यस -2 दिया था, तो एक स्कोर होगा स्टेशन -2. इफेसमेंट कितना दिया था? आई थिंक इट वाज 2 सेंटीमीटर डायलेटेड, 2 सेंटीमीटर डायलेटेड था. एंड आई थिंक सर्विक्स वाज फर्म या सॉफ्ट, क्या था? 2 ओके यस, 2 and 2 था. या ऑप्शंस वर वेरी क्लोज, आई नो दैट. या आई नो दैट. मैक रॉबर्ट मनोवर किसको बेटा? वो अलग था. यस आई एम डूइंग दैट. मैक रॉबर्ट किसको प्रोटेक्ट करता है? मतलब यस ऑब्वियसली क्लैविकल विल नॉट गेट डैमेज एंड ओब्स पाल्सी विल नहीं होगा, एंड देन यू कैन डिलीवर द बेबी आउट. एंड आई थिंक द कंसिस्टेंसी वाज consistency was the given, I think firm या medium. I think the question, हाँ soft and mid post. हाँ so soft and then mid post. Yes, okay, so you will have to, and effacement was how much? Effacement was how much also we need. So we have got here 1 is 3 and 2 5, and depending on the assessment, if it was 50% then 6 hoga. Yeah, if your station was -2, that many student told me. Okay, and depending on this assessment. So yes, slightly calculation tha, and I know thoda sa unfair hota in the exam. Yes, now this again very simple, all of you know. Again, this question is always many times asked about the lactation. Now please again tell me over here, because I have got various things. Somebody has told me कि sir lobules के बारे में पूछा था. So if it is development of ducts and lobules, ducts is mainly estrogen dependent. Lobules के लिए estrogen and progesterone is for low, ducts is for low. And if finally they have asked you, yes, if they have asked you about the myoepithelial cells, okay, last part, milk ejection. Okay, if the question is about milk ejection, then all of you know it is oxytocin. Oxytocin is for milk ejection. Yes, they mark structure. Glands and ducts. Ha, very good. So ducts is mainly gland. Yes. So ducts is estrogen, glands and ducts estrogen, progesterone both. Okay, and myoepithelial cells, if it was there, then on myoepithelial cells it is oxytocin. Overall, yes, correct. Then estrogen is correct. Overall, for lactation production, we all know prolactin. Prolactin is for milk secretion and then maintenance. Yes, perfectly correct. Yes. Okay, ducts thigh. Yes, duct was there. Estrogen is the answer there. Yes, and this I'm sure all of you sabne toda hoga. History of DNC done in a 29-year-old. Secondary amenorrhea. After that, E plus P is negative. All of you must have got it correct. That is the Asherman syndrome. So that is almost over this, and two more questions. Yeah, correct. Then yes, prolactin is correct. Asherman syndrome, I'm sure all of you must have got it correct. Okay, and yes, this was there. हाँ तो ना बेटा इट्स करेक्ट बेटा ऑक्सीटोसिन था आंसर बेटा वो डिपेंड करेगा कि व्हाट वाज मार्क इफ द डक्ट वाज मार्क आंसर इज ईस्ट्रोजन इफ दे से दैट जस्ट फॉर मिल्क इजेक्शन और मायोएपिथेलियल सेल्स व्हाट इज गोइंग टू कम दैट्स गोइंग टू बी ऑक्सीटोसिन वन मोर क्वेश्चन which was there was our obstructed labor. One was obstructed labor, and that was our Bandel's ring. Okay, Bandel's ring is keeps on moving up, up, up. Obstructed labor. And one more question they told me was Mullerian anomaly was shown. What was that? Mullerian duct anomaly. Mullerian anomaly, and they were asked which duct problem. Ha, procedure done and yes, come again. Yes. So Mullerian anomaly is what? Mullerian anomaly, which duct it is? Yes, anybody? Mesonephric, paramesonephric. It's a Mullerian duct anomaly. That's why it is called Mullerian anomaly. So that is your paramesonephric duct, correct? Because Wolffian duct and mesonephric is the same. Okay, yes, this is what, my dear student, this is the Rigen maneuver. Okay, why do we do what is the purpose of this? Yes, Swati. Okay, perfect, Swati. Okay, yes, correct. Mullerian anomaly is your paramesonephric duct. What I think unicornuate uterus image was given, image of a unicornuate was given, or whatever, paramesonephric duct. This is your actually your embryology. Perfect. And this is for what purpose? Yes, because I told you the baby's head is flexed. Baby's head is flexed, and the head delivery takes place by extension. Head delivery is by extension. Okay, so head is going to, because head is flexed and head is delivered by extension. So purpose of doing this is to prevent the perineal tear. Correct. Is this understood to all of you? Is this crystal clear to all of you? So purpose of doing this maneuver, Rigen maneuver, is to rapid repulsion. Yeah. Yes. Okay. So because head is flexed, and so you keep on maintaining the flexion. One hand is giving the perineal support. Rigen maneuver. Name of the maneuver. Please keep in mind. Surely this question is going to come. Yeah. We don't want to do rapid expulsion. Yes. So correct. Basically, it is controlled delivery. Yes. It is controlled delivery. It is controlled delivery by allowing gradual extension to take place. Very good. The purpose is gradual extension to prevent perineal tear. And this, I am so happy. I'm really telling you, last day of our live class, I told you this question, and yes, again a tough MCQ, that there is a placenta which is, and many of you will have got it correct, placenta is adherent to the uterus and it is invading into the bladder. So when it is only adherent to the uterus, we call it as placenta accreta. When it goes in between the myometrial fibers, it is increta. And yes, very good, this is the answer, placenta percreta, and very dangerous situation. You need to keep the whole team, and you will have to do the hysterectomy and life saving, and a surgeon is also required because bladder involvement and all that, very complex case. And placenta percreta is the answer. Very good, because it is invading into the bladder. If they say only, so remember this: accreta, accreta, increta, percreta. Okay, accreta, increta, percreta. That is what the how the sequence is. Adherent to the myometrium, invading I is invading, and percreta is into this. Okay, so and all of you, I'm so happy every student has told me, okay sir, once we have a look, once we have seen your video lectures, we can revise the entire notes in just 2 to 3 hours. Completely colored notes are there, my dear students. I'm wishing you that all of you are going to clear the FMG examination and are going to do well and for preparation for NEET PG. But in case if your exam has not gone well, and those who are preparing for the upcoming December examination, please do not waste time. And the 6 months master class is going to help you till the Jan, because last 2 years December exam is in January. So 6 months exam will be there till your validity, and master class, everybody, I can assure you, OBGY will become your, I am here with a single point agenda to make OBGY your most favorite subject and most scoring subject. We are going to teach you the main detailed theory lecture, rapid revision MCQ, beautiful handwritten notes, what I showed you, mock test. Of course, my timetable guidance mentorship is also there, and you can get in touch with me on phone and WhatsApp on this number. And please share this video with all your friends and colleagues. Thank you very much. Okay. LRK Vibhaki, Menarche, one question, sir. Pediatric child, so I think then you can ask the pediatrician, but small breast, good height, simply that put the Thelarche Pibarki. Yeah, Thelarche Pibarki. And then yes, okay. Yes, so this is, so actually it is accelerated growth and then peak height in velocity, and then menses would start. Okay, yes, so please follow me on Instagram also. Lots of important content we pull, and please share this video with all your friends and colleagues, and please subscribe to the YouTube channel so that you will get very more interesting video, and Telegram channel also do channel, put the PDF also of this. And yeah, thank you Orion. Yes, thank you. So thank you for all your love and appreciation, and we are so happy. Yes. Yeah, beta, that is Randir Babu, that the last day 20-day course will cover the majority, but right now those students who are there to take in for the 6 months master class. And thank you very much all of you for your love and appreciation. Yes, wishing you all the best. Do be in touch with me on phone and WhatsApp, and whenever you get results, I'm waiting to hear from you for all your passing, and all of you should pass FMG with flying colors is what I pray to God, and I wish from the bottom of my heart. Thank you, bye bye, best of luck, and thank you very much for this attending this session and giving me the questions also. Thank you.